Well, a very good morning, everybody, and welcome to the first surgical ground round of Michaelmas term and of the year. And it's a great pleasure today to introduce Sheraz Markar, who I'm sure everyone will know well. Sheraz is director of SITU, which oversees a broad portfolio of surgical trials, many of which are run by our colleagues in the NDS. SITU supports the full pathway from trial design all the way through to implementation. His own clinical and research interests are in benign and malignant esophageal and gastric disease, and he has not one but two PhDs in the diagnosis and management of esophageal and gastric cancer. His current primary research is in survivorship and surveillance after treatment, and also standardization of surgical quality assessment. Sheraz currently leads the SARONG trial in post-treatment surveillance of esophageal and gastric cancer, as well as the international GOLF trial of LINX treatment versus fundoplication for reflux disease. In 2009, he was awarded the United European Gastroenterology's Rising Star Award, and in 2020, the very prestigious Royal College of Surgeons Hunterian Professorship. He's currently Associate Specialty Lead in Esophageal Gastric Surgery of August and Deputy Chair of the NIHR Pre-Application Support Fund Panel, as well as having leading roles in national and international educational initiatives. I'd also like to mention that 2 weeks ago, he successfully completed the Oxford Half Marathon, so congratulations on that. And over to you, Sheraz. Welcome.
Many thanks for the introduction, James, and thank you to NDS for the opportunity to present today. I really like to thank actually NDS for the support actually since I started here maybe a couple of years ago now. So I'm going to talk to you really about I guess where I've come with my research and potentially where we're going, I think, as a department and as a specialty in esophageal cancer management. So I'm going to start off. I'm going to start off. I put lots of pictures of my children in my slides, partly to keep it entertaining, because it's quite sometimes difficult to concentrate on just my voice. But anyway, so I think the most important thing when we start to think about treatment, and I'm speaking specifically about esophageal cancer, but really what I'm talking about is advanced cancer here. So we have to ask the patients what's important to them. So they want to survive, obviously, but they also want to have a good quality of life after they survive. And that's something when we have patients with advanced malignancy that I often feel we don't talk about enough. And you really have to start to think about, when you speak to these patients, really, what is the goal of any intervention or their treatment? So what are you actually trying to do to them? Are you trying to really, if they're very young, are you trying to give them their best chance of survival? And maybe quality of life isn't weighted as highly, or if they're very more elderly, are you sort of more concerned about their quality of life and less about their long-term survival? So it's a balance, and it will often be individual to individual patients. I often think about this patient who I saw in my clinic, who was 84 years old. He had a proximal gastric cancer. And, you know, we were discussing whether or not to have a total gastrectomy. And what he said to me is that I want to live, but I want to live well. So in the end, he actually chose not to have surgery. But really, I guess my journey with all of the work in survivorship started with this study. So as James said, I did 2 PhDs, but my first was at Imperial with George Hanna, and really it was on developing a breath test for esophageal and gastric cancer. So I was a sort of a science guy. I was really in the lab doing metabolomics and using mass spectrometry. And then when I started my lectureship with George, that was the plan. That was what I was going to do after my PhD, is carry on the breath analysis work. And I sort of sat in my first clinic after doing my PhD with Prof. And a patient came in who'd had a resection 3 years ago. He was doing really well, no recurrence, had done great from surgery. And he was a young guy, and he's 60 or so. And I asked him, you know, essentially how he's doing. And he said, everything's fine. He said, the only problem is that I can't sleep at night. So I asked him why. And he said, I have to sleep on 6 pillows at night to prop myself up, because otherwise I get terrible reflux. So I thought that was interesting, because, you know, obviously that's a quality of life issue, which at the time, to be honest, I hadn't really discussed with any patients, and it wasn't a priority research theme for the department at all. So then I asked a few other patients after that the kind of quality of life problems that they were having, and it seemed to be that a lot of patients were suffering. They were sort of silently suffering because they didn't want to tell us as surgeons that they were having these major issues after surgery. So following that, I went back to George's office and I said, look, what I'd really like to do is change my entire research theme here, and I'd like to really look at this issue of survivorship. And you know, I'm very fortunate that George was a great mentor for me. So he said, yes, absolutely, you change to what you want to do. So that led me to setting up this study, which is called LASER, which is lasting symptoms after esophageal resection. And what I was interested in doing was really looking at what were the persistent symptoms that patients who survived a long time. So I appreciate more than 1 year may not seem to be a long time for a lot of surgeons who operate on other cancers, but in esophageal cancer, it is a relatively long time. And really to look at what symptoms had the most impact upon the quality of life in patients after surgery. So, you know, I was very fortunate to have a strong European network who were interested in undertaking this piece of research. So we involved 20 centres from across Europe. We basically tried to create a questionnaire that was broad in its nature to really look at, you know, the kind of breadth of symptoms patients had and also the functional impact they've had upon their long-term functional outcome. So we piloted the questionnaire initially in 4 centres and 40 patients. Then we did 2 international patient workshops to look at the acceptability of this after that. These were the centres that took part in the study. As you can see, it's largely speaking representing Western Europe. And to put it in context, whilst this might not seem like a large number of patients, 876, this was the largest survivorship study ever conducted on esophageal cancer at the time. So on average, patients were a median of 3 years after surgery. And what we showed is that basically we asked them initially just a broad question, you know, in the last 6 months, have you had any symptoms that you thought were associated with your esophagectomy? And around 2/3 of patients answered yes. So the burden of symptoms is quite high. Then I wanted to know, okay, so what symptoms do you actually experience daily or multiple times per day? And just over 30% of patients were having difficulty with eating. And just under 30% of patients were having regular episodes of tiredness and reduced energy or activity tolerance. And this is really interesting when you start to think about counselling patients. 3 years down the line, on average, patients are still having problems with their energy. And then when you ask patients what were the most troublesome symptoms to them, so what did they think were the most important factors influencing their quality of life? You know, really the most common symptoms patients described were problems with their GI tract. So whether that be loose bowel motions or heartburn or waking up in the night with this sensation of choking, which can obviously be quite alarming to a patient because that's in many ways how they primarily presented with their cancer. And also, as we said, these issues with tiredness and reduced energy or activity tolerance. Following this, we went on and looked at the data in a bit more detail, and I was interested in seeing, you know, basically, was there an association with how long after surgery the patients were in terms of their symptoms? And really what we appeared to see is that the GI symptoms, so the kind of the abdominal pain and the early feeling of fullness, were symptoms that were more common in the first 2 years after surgery. However, the issues around tiredness and reduced energy or activity tolerance were persistent and kind of broadly spread, even up to 5 years after surgery. As I said, my background was in metabonomics, so I was interested in applying, you know, linear discriminant analysis and principal component analysis to this data, which are 2 kind of statistical models which allow us to look at whether or not these symptoms cluster into kind of discrete areas. And really what we showed was, yes, they do cluster, and they cluster based upon a logical distribution. And what we also showed was that these clusters actually have intimate relations. So symptoms were like regurgitation and reflux are associated with problems with the conduit and swallowing. Likewise, musculoskeletal issues are strongly linked with lethargy and tiredness afterwards. And your symptoms around sort of abdominal bloating and things are correlated with your lower GI symptoms. Now, to all of us in the room who manage patients with esophageal cancer, this is not rocket science. This is absolutely true. But to actually show it in the data provided us with a great degree of confidence in this data set. The other thing that I started to notice is that, look, I worked with George Hanna, and we did a lot of open surgery. So we did a lot of open thoracotomy in these patients. And what was fascinating to me is that around 15% of patients were still taking opiate-based painkillers. And bear in mind, I should say the median follow-up is 3 years after surgery. So, I mean, this is something that had never been reported in the published literature before, but patients were really suffering with this. And I see Liz is on the call, who's one of our chief dietitians here in Oxford. And this is really important because really 10% of patients up to 3 years after surgery are still losing weight. And around a third of patients are struggling to maintain their weight after surgery. And when we start to operate on patients who are younger, and I notice in my clinic that we are seeing younger and younger patients, we ask them really about their functional return, or what their functionality is after surgery. And it's important to know that just under 15% of patients return to their normal activities as they were before their treatment. So it's a really, in many ways, a really morbid surgery in actual fact, but it does obviously represent their best chance of cure. And again, we asked them at the end, really, what kind of activities did they feel were they able to sort of return to normal activity? And the answer is not very commonly, actually. And I think that's actually increasingly important as we counsel patients before surgery. The other thing that I was interested in knowing is basically so we have a questionnaire in the upper GI literature, which is called the EORTC, QLQC30, and the OG25. These typically they're about 40 to 50 questions. And what I wanted to know is whether or not we could use an abbreviated questionnaire to identify patients with a poor quality of life based upon this more comprehensive questionnaire of up to 60 questions. So I reduced our symptoms to just basically 4 symptoms that were significantly associated with a poor quality of life. And in this data set, what I showed is that in follow-up, we were able to identify patients with a poor quality of life just based upon 4 symptoms. And we validated that internally within that data set. Following this, what I was interested in doing, we did some patient workshops after this, and really what I wanted to know was basically could we really narrow this down to 6 symptoms that then could be basically used to follow up patients remotely and say, okay, so if you have these 6 symptoms, perhaps you need a bit more support in the post-operative setting. So bring these patients to survivorship clinics, which is sort of the next step, I think, in our specialty. So we narrowed it down to these 6 symptoms, and I'm really pleased to say that we've completed this study now. It's under review with BJS, but essentially we were able to prospectively validate this tool. So this tool now is a 6-symptom tool that is able to identify patients with a poor health-related quality of life with a good accuracy, and therefore potentially identify patients who could then be brought into survivorship clinics to really help them down the line with some of these issues that they're left with. Because the most important thing is that these symptoms are potentially modifiable and potentially treatable if we are able to identify those patients with them at an early stage. Obviously, one of my areas was really in metabonomics, and as I alluded to, I was interested in trying to look at the functional mechanism that underpins these symptoms, particularly the GI symptoms, as I talked about. So these symptoms are potentially correlated with changes in the microbiome. So I have a study which we've just completed recruitment for now called Maples, where we looked at patients, 100 survivors after surgery. We collected stool, blood, and urine and saliva, along with their quality of life and their symptom scoring. And what we're just doing now is going through the analysis of that data. So we have the stool samples and saliva, which we're looking at 16S RNA sequencing for changes in the microbiome. And we have blood and urine, whereby we're looking at changes in volatile organic compounds and correlating that with their symptoms as well. So really trying to look at potentially the functional mechanism that underpins some of these symptoms patients are left with. The other thing that I talked about was thoracotomy related pain. And I know some of my surgeons, along with myself, do a minimally invasive approach, but still you have to do a thoracotomy to take the specimen out. And so I should say I played a lot of cricket when I was younger, and one of the things that we used to do is we used to wear sensors on our body to really look at how our bowling action was and whether or not we could improve the kind of efficiency of bowling. So I thought whether or not we could apply the same principle to the chest wall after patients after surgery. So we essentially brought around 20 patients into the lab, and we placed these sensors all over their body. And ultimately, what you end up with is this kind of dimensional model of a patient's thoracic cavity. And from that, you're able to break down the chest wall into a series of segments, and it gives you a series of areas that you can really focus on. So you could, in theory, look at the specific aspect you've operated on. So the specific area in the thoracic cavity that may be associated with breathing patterns. And really, the ethos of this project was trying to distinguish the lung from the chest wall. So what contribution in a patient after esophagectomy is the chest wall making versus the lung? So what we were able to do is break this down and really show that patients after esophagectomy, and the Vicon data is probably the most interesting data here. But when comparing patients to controls, what we're able to show is that their breathing patterns are extremely different. So these patients are associated with after surgery associated with profound problems with their chest wall in terms of the way that it moves, and that's linked to their breathing capacity, which ultimately is linked to the patients who suffer with reduced energy and activity tolerance. The other thing that with this data that we're able to do now with the Vicon is we're able to break down the contribution of the chest wall versus the abdomen. And I think this is very interesting because now what we're able to show is that in patients who've had a esophagectomy with an open thoracotomy and an open abdomen, is that their relative contribution of their chest and their abdomen to their breathing pattern is very different compared to a normal person. Normal person, it sits at about 50-50. In a patient after esophagectomy, it's profoundly different based upon ultimately their pain. So this starts to make us think about, in the immediate setting after surgery, is this potentially a scar tissue issue? So could we give patients tailored physiotherapy specific to patients who are having esophagectomy, specific to how they breathed before surgery, that may potentially reduce these problems with breathing down the line? And that's a study we hope to do down the line. The other aspect that can't be ignored is the psychology. So for those of you who don't know, is both my parents are psychiatrists. So that's partly why I'm such a well-adjusted personality for being a surgeon. I say that tongue in cheek, but anyway. So one of the areas that I was really interested in is looking at national data. So I did a lot of work with HES and CPRD. And one of the things that I was interested in knowing is that in patients after esophagectomy and gastrectomy, how many of them have depression and anxiety? And one of the things that we looked at a whole host of GI surgeries, so HPB, upper GI, colorectal, cholecystectomy, bariatric surgery, and so on and so forth. And we showed that after surgery, around 14% of patients with esophagectomy and gastrectomy will have a diagnosis of depression or anxiety that requires medical therapy. When we look at that in terms of an odds ratio, esophagectomy and gastrectomy is the highest predictor of having postoperative depression or anxiety, which is to me was quite alarming, particularly when I looked at bariatric surgery as an indicator as well. And then when we showed at 1 year, in terms of survival, if you have newly onset diagnosed depression or anxiety, that is independently associated with 1 year mortality, independent of your cancer stage. So these patients are struggling to cope after surgery, and that is intimately associated with their 1 year mortality. And when we look at the data from Sweden as well, there is a high rate of suicide, which can't be ignored in these patients after surgery. The other thing I wanted to do was bring the data together. So I wanted to know, okay, so if you have a high burden of symptoms, is that associated with depression or anxiety? And the answer is yes. So if you have 2 or 3 symptoms, your chance of having depression or anxiety after surgery is much higher. I went on and I did a lot of workshops with these patients, and one of the things that they were really worried about was they were really worried about their cancer coming back. So at the time, around 2/3 of patients who have esophagectomy or gastrectomy, their cancer would return in 3 years. And that's, that's the alarming truth of the nature of the issue that we're dealing with. So we went on and I became interested in this issue of surveillance. So I thought, okay, if we followed up these patients basically with aggressive CT, does that, maybe reduce their anxiety or depression? And does it maybe improve their overall survival? So I started becoming interested in trials. As James alluded to now, I work here in our surgical trials unit. And so you need to start to build a rationale for a trial. So this was the guidelines at the time, which is from our European Society of Medical Oncology. And they stated that there is no evidence that regular follow-up after the initial treatment, so after initial esophagectomy or gastrectomy, actually impacts survival. So following this, I went on and did a study called ENSURE. This was a multinational, international study, and we started off with a survey, and these are 30 of the highest volume centers in the world actually performing esophagectomy and gastrectomy, in the Western world, I should say. And what we asked them was whether or not they felt that intensive surveillance would actually meaningfully impact survival. And as you can see, there's a broad range of views. Secondly, I asked them, did they believe that this would reduce the anxiety of the patient? Again, there's a broad range of international views. And these are the highest volume surgeons. So these are surgeons who are performing surgery, on hundreds of patients per year. And we can't agree. Then we collected data from just under 5,000 patients, and we broadly broke down the centers into intensive surveillance versus standard clinical follow-up. So that was if you did a scan regularly, i.e. once a year on a patient to look at whether or not they had a recurrence. And what we showed was that if you were a patient that was having intensive surveillance, that was able to identify 8 patients who are asymptomatics, i.e. if you had recurrence in asymptomatic patients, it was able to identify it. It was also able to identify recurrence potentially at an earlier stage, so either local or anastomotic recurrence, so i.e. potentially treatable disease. And what we showed is that if you went after that recurrence and you aggressively treated it, then that was able to potentially improve the overall survival of these patients down the line. Following this, I really wanted to know specifically in the UK, how are we following up our patients? So the pie chart in the top of the screen really shows this. So we collected data from 28 UK centres. Bear in mind, there are only 32 who perform this type of surgery in the UK, so we had good coverage. What we showed was that in actual fact, there is no agreement. So basically, as a country, we break down into quarters. So there are 29% of centres who standardise this for patients. There are 26 who tailor it based upon, the pathology of the patient, for example. And there are 17 who perform no surveillance at all. And then I asked centres, okay, would you be interested to take part in a randomized controlled trial? And broadly speaking, there was good agreement that, this is maybe an area of interest we might want to research. The second thing I wanted to know was that basically it wouldn't be, I didn't think it would be palatable to patients to be randomized to, having a CT every 6 months versus having nothing. So what I wanted to know was what kind of symptoms would trigger a CT scan potentially in the control arm. So we went through an international consensus and we published this again, whereby we said, okay, these symptoms are potentially associated with recurrence. What I have now coming, which I think is an exciting project, is whereby I've collected data from the last 15 major randomized controlled trials in Europe, and we're looking at whether or not, based upon these symptoms in that randomized data from these major trials, we can identify patients with recurrence using a symptom model. But this led us all this work to build us towards this trial, which is called SARONG. So as some of you know, my background is Sri Lankan. I played under 19 cricket for Sri Lanka, so I'm very proud of my heritage. And SARONG is our national dress, which is nice to have this trial named after. So the aim of SARONG is really to really identify whether or not intensive surveillance in patients who are treated curatively can improve overall survival and the quality of life in patients having esophageal and gastric cancer surgery. So patients after surgery are randomized to either intensive surveillance or standard clinical follow-up. So the intensive surveillance involves a clinical review and a CT every 6 months for the first 3 years, plus an endoscopy at 12 months. And clinical follow-up is clinical review at the first 6 months and at 12 months, and then really up to the center whether or not they follow up their patients. I appreciate that may be alarming to some of us in the room, as in Oxford we tend to follow up our patients at least annually. But there is a broad range of views as to whether or not that makes any difference. And so this trial is a pragmatic trial and really reflects the breadth of opinions in the UK. So this trial is running now. As I say, this is the protocol. We've been funded by the NIHR HTA to 2.7 million. We're including now actually 30 UK sites. The sample size of this trial is 952 patients. So far to date, we've recruited just under 380 patients. So this trial at the moment is the fastest recruiting trial in the setting of esophageal and gastric cancer that has ever been conducted in the UK. And I think in Oxford, we should be very proud that we've been able to design this trial and implement this trial at a national level. The second thing that I think is very exciting is at the time when I put through the grant application, I had a dual affiliation with Karolinska in Sweden. So I had funding from the Swedish Cancer Society and the Swedish Research Society to undertake a trial in Scandinavia. The NIHR feedback was that they didn't want a European trial. They just wanted a UK-only trial. So I decided in parallel to run an international trial called SARONG 2, which is running across Ireland, Sweden, Norway, Finland, Germany, France, and Italy. And this is interesting because this trial is just started, so it's a bit behind the UK trial. But it's the first time that we've been able to run a trial in UK and internationally with exactly the same study design. So it's powered to 952 patients with exactly the same primary endpoint and exactly the same metrics being collected at the same time points. So we have duplicate trial designs. And what's exciting about that from my point of view is two things. One is that I believe we will potentially be maybe more conservative in the UK as to how we treat recurrence. So we may be able to identify recurrence at an early stage, but we may not see the overall improvement in survival because we don't treat that recurrence aggressively. However, in Europe, they've gone through a project called the OMEC study, whereby they have mandated now, and it's part of guideline practice in Europe, that if you identify single site recurrences, that you should be treating that aggressively with either local regional therapy or best systemic therapy. And so my feeling is that maybe the European trial might be positive and maybe the UK trial might be negative, or we'll see. But also the other thing that's exciting is we'll be able to put the data together at the end of both trials. So we'll have over 1,800 patients and we'll be able to really get down to the nitty gritty as to which patients really benefit from aggressive surveillance versus those that don't. The other thing that I think is exciting and is that we are coming with a couple of UK trials really from Oxford, which is on the sort of cusp of where we're going. And so in my role in OGIS, one of the things that happened was that our national audit for esophageal and gastric cancer closed. So the government said they weren't going to fund this, and I thought this was really outrageous, in all honesty, because I think it's a hugely valuable data set. So I approached OGIS, which is our national upper GI society, and I said, what I want to do is I want to create a platform for future clinical trials, and I want to run them from Oxford. So within that, I wanted to not only collect survival data for the patients, but I wanted to collect patient-reported outcome measures. So we are putting through a grant now for a trial called POPIO, which will be the first study in the UK ever to collect in a longitudinal fashion patient-reported outcome measures and quality of life in these patients. And what's exciting about that is that, if Southampton have a trial that they want to do, they may want to do a trial comparing, one type of chemotherapy with another. We will be able to collect the follow-up data from Oxford for that trial. So we ultimately will become the centre for future esophagogastric trials in the UK. Potentially using this platform. So we put two funding applications together for this trial, which I think is very exciting. The second thing is I'm working with Alex Gordon-Weeks and Lizzie Smythe from Medical Oncology in designing a trial called ROLOGO. And this trial is looking at whether or not we can treat patients with advanced malignancy. As some of our specialist nurses and my colleagues on the call will know, at the moment, I do resect patients with single-site metastatic disease along with their primary tumor. So this is patients who have low burden metastatic disease. So using the OMEC definition, so that's metastasis in the liver, up to 2, or in both lobes of the liver, or 3 in a single lobe of the liver, and lung metastasis and adrenal metastasis. And what we're trying to see is whether or not we can give these patients optimal systemic treatment, and then either stop that chemotherapy and continue the biologics for a few weeks after that, and then randomize them to either a resection of their primary cancer and local regional treatment of the metastasis versus best systemic therapy. I urge my colleagues to not say it's palliative, because I don't think that's correct in the current era. It's the best systemic options available for the patients. After surgery, patients will also be offered chemotherapy or immunotherapy up to 2 years after surgery. What I think is very exciting about this trial, and we were putting through an HTA application in January, is that this trial will have a co-primary endpoint. And I know Freddie has a trial in prostate cancer, which is similar in many ways with a co-primary endpoint. But I think this is the future of randomized trials in major cancer surgery, is that we have to look at whether patients survive, but also whether they survive well. So in actual fact, weight the quality of life to an equal value as the overall survival of those patients. The other thing is that I want to look at the functional recovery of these patients. So Kerry, who's on the call, is an academic clinical fellow who's outstanding and working on a project with Neinica, my PhD student, really looking at whether or not we can look at the functional recovery of patients after esophagectomy using wearables. And that's something we hope to validate within this trial. So just to conclude, I'd really like to say that I think patient-reported outcome measures and quality of life is crucial in outcome assessment after patients have had esophagectomy or gastrectomy. I think the functional recovery of these patients can be objectively measured and correlated with their subjectively measured quality of life, and I think that's the direction of change. More and more trials are going to have to start to use these paired health-related quality of life and survival as a composite measure and as an overall outcome for these patients. And I go back to the original quote of my 84-year-old in clinic, which is that I want to live, but I also want to live well after this surgery. So I'd like to thank you for your time, and I'll stop there, and I'm very happy to take any questions.